everyone, and welcome to Beyond ACE webinar, which is a partnership of Ascend at the Aspen Institute and the National Crittenton Foundation. We appreciate you joining us today. My name is Jennifer Miller, and I am with Child Focus and the National Crittenton Foundation. I'll be the moderator today. And I am going to first give a brief overview of what the webinar is all about today before turning it over to Sarah Haight with Ascend to talk about some housekeeping things, as well as to provide an overview of Ascend and its two-generation work. We'll then, after Sarah presents, hear from Jeanette Espinosa, President of the National Crittenton Foundation, who will talk about the second administration of the ACE. As well as Dr. Roy Wade, who will provide an overview of the findings from the ACE research conducted by National Crittenton Foundation. We'll conclude the webinar with a presentation from me about the toolkit from providers that was developed by the National Crittenton Foundation. We'll be providing an overview of the contents of that in hopes that other providers will be able to use some of the experience of the National Crittenton Foundation in administering the ACE survey. I'm now going to turn it over to Sarah Haight, who is a program manager at Ascend at the Aspen Institute. Sarah earned her Master's Social Work degree from Silver School of Social Work at New York University. She's worked as a therapist in direct practice clinical settings with low-income women in New York City. And she is licensed to practice social work in New York and the District of Columbia. She received her bachelor's degree from Barnard College. I'm going to let Sarah share more about Ascend and their specific interest in ACE's work. And I do want to mention that Ascend has been a wonderful partner and supporter of the National Crittenton Foundation and their ACE's research, and provided funding for the provider toolkit that you'll hear more about later in the webinar. Sarah.
Thanks so much, Jennifer. We're so glad to have so many of you on the webinar this afternoon, and I know you're really excited to learn more about the toolkit and the research from the webinar, so from the toolkit rather. So I'll try and make my remarks brief. I'm going to kick off actually with a few housekeeping notes for the webinar itself. The webinar is going to last for about an hour and 15 minutes, and we'll conduct Q&A with our speakers in the last 10 to 15 minutes of the webinar. We're also recording this webinar, so for those of you that need to leave early or want to share the content with colleagues, we'll post the webinar on our website by the end of the week. Please note that as participants, you all are muted, so if you wish to ask a question, you should use the raise your hand icon on your screen. And then during Q&A, if you wish to be audible for your question, you must log in using your audio PIN number. Otherwise, you can simply submit a question through the message box on the screen, and we'll review it and share it at the end. So this webinar is part of a series of webinars that Ascend has been hosting in 2015 and throughout 2016, featuring our network partners and their two-generation projects and initiatives. And Ascend is very much still in the learning phase of its work with regard to the intersection of trauma, health, and two-generation approaches. So we feel very fortunate to partner with the National Crittenton Foundation, which has been doing this work for decades, to explore how a trauma-informed lens can create better results for families using a two-generation approach. So I'm going to start with just a quick overview of what the two-generation approach is. And this is something that some of you may be familiar with, but not everyone. So research has documented the impact of a parent's education, economic stability, and overall health on a child's trajectory. Similarly, children's education and healthy development are powerful catalysts for parents. So two-generation approaches provide opportunities for and meet the needs of low-income children and the adults in their lives simultaneously, helping the two generations make progress together. So there are 5 key components of the two-generation approach, and we'll be talking much more deeply about health and well-being in this webinar. We know that the return on investment in early childhood is as high as 7 to 10%, so early childhood is a key component of the approach. We also know that post-secondary education is critical because a parent's educational attainment can be the single best predictor of that family's economic mobility. Economic supports are also critical, so supports like the Earned Income Tax Credit and asset-building tools like child savings accounts. And if, Jennifer, if you could mute yourself, I think that we can hear you in the background.
we're not doing, like, it's just the bad.
Social capital is also critical. It's the secret sauce of two-generation approaches, as we call it. And this is the web of relationships among individuals and institutions that help all families thrive. And then last and not least, health and well-being. So if a parent or a child...
Sarah, if I could interrupt for one moment, if we could ask everybody on the webinar to mute themselves. We're hearing a lot of background noise. That's much better. Thank you very much. Sorry, Sarah.
That's all right. And then the last component is health and well-being. So if a parent or child is unwell physically, emotionally, mentally, it's very challenging for a family member to participate in school or function at a job. So ensuring access to quality, affordable health care, including mental health care, is critical. And we'll talk a lot more about that today. So why a two-generation approach now? We know that there are policies and systems that are designed to support families that often work in silos, separately. So we have been working to build a field along with nonprofits, philanthropic organizations, and policy and system leaders to build an awareness of what the data tells us. As I noted, the high return on investment in early childhood paired with the economic gains by parents with higher education levels. And these two things inform the two-generation approach. At the same time, the field of brain science is yielding important findings. While learning to cope with adversity can build resilience and is an important part of development, prolonged exposure to traumatic conditions, including neglect and abuse, as well as food insecurity and poverty, can have long-term consequences for brain development. And these factors can then influence a child's long-term outcomes in learning and in health. So just briefly, we at Ascend at the Aspen Institute, with the influence of this research and a growing need to build on what works, have been created to focus on the two-generation approach, both over the last 5 years and in the years to come. Our vision is of an America in which a legacy of educational success and economic security passes from one generation to the next. We have 3 key strategies. We elevate and invest in a portfolio of solutions. We build leaders and networks. So our network includes 58 organizations in 24 states and the District of Columbia right now, and the National Crittenton Foundation is one of our partners. And we engage the voices of families to inform our policies and programs. At the heart of our work is, the family, the parent, and the child, and we're pleased to partner with the National Crittenton Foundation on some of our work around bringing families and parents to the table of all of our events and our meetings. And just lastly, before I turn the car keys back over to Jennifer and Jeanette, I wanted to share a couple of high-level lessons from our work on health. So what have we learned about health and 2Gen over the last 5 years? One is very straightforward. Social determinants of health impact economic well-being. We've also learned that key human services levers like food assistance and case management must be connected to health policies and measures. Research on adverse childhood experiences, which we'll talk more about today, brain development, and toxic stress must effectively inform best and next practices for families. And from a policy perspective, we've also looked at how to leverage opportunities in the Affordable Care Act to improve economic security and family health and well-being. And more of that is available in our report called Top 10 for 2Gen on Ascend's website. So thank you again for all of you for being here. And Jeanette and Jennifer, I'll turn it back over to you.
Terrific. Thank you so much, Sarah. I encourage you all to get on the website of Ascend. There's some wonderful tools, wonderful resources, wonderful archives of past webinars. There are great research on two-generation approaches. So next I'd like to introduce Jeanette Paez-Spinoza, President of the National Crittenton Foundation. She's going to give you some background on Crittenton Agency's ACES project and some context for the second administration of the ACE before we go into what some of the findings of the ACE project have been. Jeanette assumed the leadership of the National Crittenton Foundation in January of 2007. She brings over 40 years of experience in advocacy, education, public policy, strategic communication, program development, I have to take another breath, and direct service delivery to Crittenton, direct service delivery. Crittenton is a 132-year institution with a strong foundation for meeting the needs of marginalized girls and young women. Jeanette's also co-director of the National Girls Initiative, which is funded by the Office of Juvenile Justice and Delinquency Prevention. So Jeanette, I'm going to turn it over to you now to give us a little background as to why Crittenton decided to use ACES.
Wonderful. Thank you, Jennifer. And again, welcome to everyone that's on the call. What you're looking at now is the product of some introspection that the foundation that we undertook about 5 years ago. It's really wonderful. People say, oh, it's wonderful, you're 132 years old. The flip side of that is, we at some point really began to realize that, the population of young women, girls and young women and women that we support have not changed dramatically in their life circumstances and the challenges that they face over the last 100 years. So we had to sit down and ask ourselves honestly, how are we part of the problem? How are we perpetuating, the cycles that were resulting really in not a lot of change for them? And one of the ways we did that was to really think through and put together this model that really it is a cycle. We call it the vicious cycle. It has no beginning, no end. It's very you can look at it across generations, and I think what is important in it is that everyone experiences adversity as a child. Some people have buffers, some people don't. If you have the buffers, then you don't really move into sort of the toxic stress, complex trauma, lifelong impacts on your life. Same thing if you have buffers at that stage. You may not as fall deep into the poor outcome sector in terms of jobs, education, health. And again, if you have buffers at the poor outcomes, you're getting good support, you're going to be buffered from moving into sort of living in low-income situations, and the cycle continues. Really no beginning or no end, but we found, and I think a lot of you, I've heard a lot of conversation very similarly about the silos. Sarah mentioned it, and if you look at this cycle, our systems are based on the poor outcomes. So we have not been backing up to look at adversity and trauma, and we have not been both looking forward and back in terms of poverty alleviation to say, it's great to help support people in furthering their education and getting good jobs, living wages, but if we're not also looking at their mental health and helping them to address the trauma that may have occurred in their life, the cycle's going to continue. And so for us, learning about the adverse childhood experiences and even pushing beyond sort of the traditional definition of the 10 factors that ACE represents into bullying and stalking, cultural trauma, exposure to war, community violence, sort of intersectional oppression, and how those impact a person's ability to overcome the barriers that come up throughout the cycle, and also how 2Gen approaches at every point in the cycle can really lead to a lot of solutions. So that's kind of broadest context, through which we looked at how we would use the adverse childhood experiences in our agencies. You could advance the slide, Sarah. So the first time we did the ACE was in 2011-2012 in our agencies. We represent 26 direct service providers who provide services in 32 states and the District of Columbia, and we're really interested they were really interested in using the ACE in their agencies for a couple important reasons that you'll also see reflected in the toolkit when Jennifer talks about it. But part of it is in doing advocacy work at the local, state, and national level, how do you describe the challenge and the adversity and the obstacles that confront a population? We struggle with that a lot. We all use terms like at risk, marginalized, disadvantaged, disenfranchised, but what does that really tell us about how we need to effectively support them so they can, be healthy and thrive? And when we discovered the ACE, we thought perhaps this is the tool. So that's part of how and why the agencies and we at the national level looked at the advantage of using it, but also at the service level, it offers the opportunity to kind of do a quick overview or a quick triage of what is the stuff that the young women are coming into their Crittenton agencies with. We don't use it as a clinical assessment. It was not designed for that, and that's certainly not how we use it. But that is why the agencies and we were very excited in 2011 and 2012 to administer it. We moved very quickly into the administration, taking very much the philosophy that let's try it and let's see what happens. We're not going to strive for perfection. We're going to learn from it, and then we're going to do it a second time. And so what you see here on the slide now is really what were the things that we learned and what did we do differently in the second administration. At the end, we'll talk about sort of what's the next stage for us, but this is for the second administration. We developed protocols This is all led by the agencies. The agencies have come together to form what we call Catalyst, Research and Action, so they very much direct, make decisions about the research themselves, because they want to ensure that the application of the results goes right back into practice and policy rather than sitting on a shelf somewhere. So protocol, standardized training for staff administering the ACE using a more robust data system. We were lucky through Dr. Wade to be able to use the Children's Hospital of Philadelphia system, and very, very lucky to have Dr. Wade on our team. We broadened the demographic section really to include some other factors like country of birth, and then added some additional outcomes. For example, asking whether individuals were trafficked for sex. And even more importantly, and that's why this is all called Beyond ACE, we began what we had always intended, which was to really connect ACE to well-being indicators. So, your ACE score is where you start, but it doesn't define you. So really to move beyond that, we had always intended to double that up and look at well-being questions and how those two link. So this time the agencies made the choice to have some of them, I believe it's 6 or 7 of them, pilot a set of well-being questions in the domains of connection, stress, and coping. And Dr. Wade will talk more about what we saw in a minute. Next slide, please. So this is simply the list of agencies that participated this time around. Next slide, please. I think that's it for me for now. Go.
Terrific. So, Sarah, I assume you've turned the keys over to me again, because I'd like to introduce Dr. Roy Wade, as Jeanette mentioned. Dr. Wade has been an amazing partner to the National Crittenton Foundation through all phases of the second administration of the survey. Dr. Wade is an expert around ACEs and the implications, particularly for low-income and minority communities, and he has done great work in Philadelphia around ACEs. Dr. Wade is a pediatrician with Children's Hospital of Philadelphia, where he's both a researcher on ACEs as well as a practitioner who sees patients weekly at a primary care clinic in Philadelphia. He's a Stoneleigh Foundation Fellow and is in the process of building an assessment tool that pediatricians everywhere can use to identify childhood trauma early so that these children can be better connected to the support and resources they need, which is really all of our dreams for how ACEs research can be applied in the real world. He's also developed a youth-informed ACE and has been very active on the Philadelphia ACE Task Force. When I say we truly could not have done the second administration of the ACE with Dr. Wade, it is not an overstatement. So I would now like to turn it over to him to talk about some of the findings from the Crittenton second administration.
Thank you, Jennifer. Hello?
Go for it.
Thank you, Jennifer, and my thanks to Ascend and the National Crittenton Foundation for including me in this webinar. As Jennifer said, I'm a pediatrician and doing a lot of work around ACEs here in Philadelphia, and I am currently a Stoneleigh Foundation Fellow, and the primary portion of my work is sort of expanding on what we consider an ACE, but also thinking about how to incorporate ACE assessment and ACE and trauma-informed practices into the work of health and social service organizations here in Philadelphia. So this is some general background. I know many of you are familiar with the initial ACEs study, but just to give you some framework on why I do the work that I'm doing. As a reminder, the ACE study was published by the Centers for Disease Control and Prevention in Kaiser Permanente in 1998. It looked at the prevalence of 10 childhood stressors amongst the population of Kaiser's policyholders. On the right-hand side of your slide, you see these items outlined in the table, and essentially, as we all know, they are comprised of 3 domains: abuse, be it physical, psychological, or sexual; neglect, be it emotional or physical; and household stressors, so things like having a substance abuse and care provider, mental illness in the home, domestic violence in the home, having an incarcerated care provider, and divorce or separation. And the power of this study is that it showed the high prevalence of many of these experiences amongst the mostly white and middle to upper middle class population, but it also showed, next slide please, a dose-response relationship between your ACE score and many of the leading causes of disability and death in the United States. Here I've outlined results from many of the initial ACE studies categorized into 3 basic domains: health risk behaviors, mental health conditions, and physical health conditions, with 5 of the leading causes of disability and death in the United States outlined, and all of these have shown a statistically significant association with an individual's childhood adversity. Next slide, please. But in thinking about those ACEs, what we knew in Philadelphia was that they don't comprise many of the traumatic and stressful experiences that kids may have growing up, particularly in urban economic distress. We know that many of those conventional ACEs, as we term them, are at least found more commonly in economically distressed settings, but don't include things like exposure to violence, feeling like you live in an unsafe neighborhood, experiencing racism or discrimination, foster care, or bullying. And so based on some qualitative work that I had done with young adults who grew up in economic distress in Philadelphia, we identified these 5 additional items or areas of adversity, which we termed expanded ACEs. And we replicated the ACE study here in Philadelphia, surveying more than 1,700 of our adults, individuals ages 18 or older, asking them about their experience of conventional ACEs growing up or expanded ACEs. And what we found was that many of the individual ACEs were actually more prevalent amongst our population, but we also found that the expanded ACEs were quite prevalent and also associated with many of those health outcomes that I outlined in the previous slide. Next slide, please. One of the more shocking findings, as I said before, is that many of the initial ACEs were quite common, or more common than in the initial Kaiser CDC study in our Philadelphia population. So this slide shows the prevalence of your total ACE score. Now this score ranges from 0 to 14 amongst our study population. And the point here that I want to make is that almost 40% of our respondents endorsed 4 or more ACEs. And as you will remember, the 4 or more ACEs is that marker for increased risk for poor health outcomes. And we're saying that almost half of our population, or at least our respondents, had an ACE score of 4 or more. Next slide, please. But as you'll see, and we'll highlight this in our talk, the Crittenton population, particularly the young ladies who are receiving services amongst these agencies, are a highly traumatized population, and their experience of childhood adversity overshadows the experiences that were endorsed from our study. So this shows the demographics from our population. As you can see, most of the population was less than 18 years of age. We purposely tried to survey young women. We got a diverse range of individuals representing individuals from different races and ethnicities. And to be expected, since most of our population was less than age 18, the majority of our population had not graduated from high school as of yet. Next slide, please. We found that the majority of our respondents were either receiving mental and behavioral health services, supportive housing services, or were in residential treatment facilities, particularly for the female population. Next slide, please. We also found that the majority of our population were either living with their family or within a residential treatment facility. So just to give you some background in terms of where and what sort of services these young men and women were engaging with when they took our survey. Next slide, please. And just looking at the prevalence of ACEs amongst the population, it was astounding to me. As many of you probably know from reading the prior ACEs study, the way we typically model your ACE score, instead of going from the full range from 0 to 10, is we create a categorical variable ranging from 0, 1, 2, 3, and 4 or more ACEs. And that typically does a good job in terms of modeling the risk of individuals. What we found in our study was that if you tried to break down your ACE score within those categories, that it actually wasn't sufficient to actually capture the level of adversity that these young men and particularly young women were endorsing. So this slide shows you the prevalence of individuals in the categories of 0 ACEs, 1 ACE, 2 ACE, 3 ACE, or 4 or more ACEs for our Crittenton study, particularly for girls, and then for the entire population. And then from the Philadelphia ACE study, as marked as denoted in the pink, and from the Kaiser CD study as denoted in the red. And what you see is that for the Philadelphia ACE study and the Kaiser CDC study, you see this sort of steadily decreasing prevalence of individuals as you go from 0 to 4 or more ACEs. But what you see the reverse in our study, in that actually individuals, the prevalence of individuals actually increases as you go from 0 to 4 or more ACEs. And what we found is we actually had to create to cut the ACE score in a different manner in order to adequately model the adversity that these young men and women were endorsing. And what we chose to do was set cut points from 0 to 3, and then 3 to 4, and then 4 or more ACEs to try to capture the adversity that individuals were endorsing. Next slide, please. And then just thinking about what are the individual experiences that our respondents were endorsing, we looked at the individual ACEs and the prevalence of individual ACEs amongst our study population and compared that to the Philadelphia ACEs study. And the point here is that, and we'll highlight this point in a little bit, that a little bit later in our talk, is that our individuals endorsed an array of different traumatic experiences, and it wasn't just one adversity that they highlighted. It gets to the point that pretty much in every area of their lives they were experiencing significant stress and trauma, particularly in comparison to the adults who were surveyed in our Philadelphia ACEs study and the Kaiser CDC study. Next slide, please. So this provides the example that I highlighted before. This is a bar graph showing the prevalence of the ACE score for Crittenton males and females, broken down in our new categories. And sorry, I misspoke earlier. Our new categories were 0, 1 to 3, 4 to 7, and then 8 or more ACEs. And the point that I want to highlight here is that you actually don't start to see a takeoff in terms of the prevalence until you get to 3 or 4 or more ACEs, and you see a significant population, particularly for the young women who are endorsing 8 or more ACEs, which just highlights that these young ladies are experiencing trauma throughout their lives, and these are repeated events that they are endorsing. Next slide, please. And then once again highlighting that it's not one particular adversity, but a range of different traumatic and stressful experiences. So these are once again the prevalence of individual ACEs by male and female. And what you can see is that for for the women in particular, they highlight things beyond what we traditionally think they would endorse in terms of adversity. So things like sexual abuse are common in their lives, but also things like emotional abuse. And actually the most commonly endorsed diversity is divorce or separation and emotional neglect. And so just trying to figure out what specific adversities or challenges these young men and women are endorsing is actually not sufficient. And it's really about a range of different traumas that are ongoing in their lives. Next slide, please. And then we found that ACEs cuts across race and ethnicity. One of the major focus of my work here in Philadelphia is how ACEs may contribute to disparities in health, particularly for African Americans and Hispanics. One of the things that we found in our work is that individuals, despite their race, were endorsing significant adversity. So this slide shows the prevalence of ACE scores by white, black, Hispanic, and multiracial populations. And we have this data also. It will be in our report broken down for Native American and Asian Pacific Islander as well. Next slide, please. And then we wanted to see if you looked at individuals who endured significant adversity, meaning 4 to 7 ACEs or 8 or more ACEs, was there a difference? Was there one particular adversity that they highlighted? And once again, we really didn't see such a pattern. For individuals with 8 or more ACEs, just by definition, they're going to probably endorse all of these experiences. But when looking at the population who endorsed 4 to 7 ACEs, as highlighted in the green, for women, we saw once again that emotional abuse and separation or divorce were actually more common than things like sexual abuse or other abuses in their home, like such as physical abuse or domestic violence. Next slide, please. And then we wanted to start to look to see if these ACEs were associated with any outcomes of interest. And so we asked, as Jeanette said, a lot of questions in terms of service utilization and outcomes to see if there was a pattern that we saw in terms of adversity. And so this slide shows you the association between the number of out-of-home placements and the individual's ACE score. And the point I want to highlight here is that particularly for the young women, as their ACE scores increases, the number of out-of-home placements that they have increases as well. Why is this important? Because what may be going on is that these young women come to their placements with significant adversity and trauma and are triggered by things that go on within these facilities such that they are at increased risk for being transferred to future facilities. And what it highlights is the need to understand the adversity profile and the trauma that they bring with them in order to try to minimize the number of placements that they have and provide some sort of stability within their lives. Next slide, please. And they also looked at ACEs in their relation to the time of the time that females had spent with an agency. And what we found is that this slide shows you the prevalence of individuals by ACE score who had been with an agency or an organization for at least 1 year. You see that same relationship as the ACE score increases, the number of individuals who have been with an agency for more than a year increases as well, highlighting that because of the traumatic experiences that these young women may have, it may require that they need more services, and it may actually lead for them to be engaged with agencies and organizations and receiving services longer than they may have otherwise. Next slide, please. And then we found that there was a significant number of women with high levels of trauma who were in residential treatment facilities. And so here you see a pie chart of the individuals, the females in residential treatment facilities by their ACE score. And the point I just want to highlight here is that more than half of the population had an ACE score of at least 4 or more, and almost more than a quarter of that population had an ACE score of 8 to 10. Next slide, please. And then this shows ACEs as they relate to pregnancy outcomes. And on the left-hand side, you see a pie chart showing ACE scores for females with at least 1 child. And what you see once again is that more than half of that population has an ACE score of at least 4 or more, and almost a quarter of that population has an ACE score of 8 to 10. And then on the right-hand side, you see a pie chart showing ACE scores for females with their first pregnancy prior to age 18, and you see the same pattern. Why is that important? Is because we know that ACEs are intergenerationally transmitted, and it highlights the need, as was said before, for that 2-generation approach. There's been prior studies showing that, doing population-level studies showing that in high ACE populations, the prevalence of ACEs actually increases with each generation. And so if we know the impact on the brain and development and the health and well-being of kids, any services that we provide to highly traumatized populations needs to have a 2-generation approach and think about ways to mitigate the transmission of ACEs to those future generations. Next slide, please. And then increasingly we've become aware of the high prevalence of trafficking amongst this population. And I don't think it would surprise anyone that these are individuals who have been highly traumatized, and we showed this with our work. This slide shows the prevalence, the ACE score prevalence of individuals who had endorsed the history of tracking, and once again you see that same dose-response relationship that you saw from the initial Felitti-Honda studies as well, highlighting this population as a particularly vulnerable population that's at risk for being victimized in many ways and later in life beyond their initial childhood experiences. Next slide, please. And so thinking about how do ACEs impact a kid, or the risk that kids may have who are born to high ACE parents, we wanted to see if we could start to look to see what were the ACE scores of respondents who had kids. And so we offered individuals, this was totally voluntary, we offered individuals who took the survey the opportunity to provide an ACE score for their kids as well. And so you see the demographics for this population. I believe it was about 109 kids total for who we were able to assess. You see the age range for this population. It was mostly male, and once again, an array of different races and ethnicities. Next slide. And unfortunately, as you'll see in a second, we saw a high prevalence of ACEs amongst this population. This slide shows you the prevalence of the individual ACEs amongst that population. So you see these are individuals who are endorsing high levels of parental separation, domestic violence in their home, or experiencing, mental illness and substance abuse problems in their home. And it's unfortunately sums up to high ACE scores for kids, particularly early in life, as you'll see on this next slide. And so this slide shows you the prevalence, the ACE score prevalence amongst this population. And what I want to highlight for you guys is if I flip this slide over and actually bunched up the 4 more ACEs, this slide will look quite similar to the prevalence that you saw for the initial Philadelphia ACE study and the Kaiser CDC study. Why am I highlighting that point? Well, what I'm telling you is that kids who haven't even, they haven't reached adulthood yet, who are born to highly traumatized young men and women or young females within the Crittenton organization are endorsing a similar prevalence of adversity as adults from our Kaiser study and from our Philadelphia ACE study, highlighting that point that I said before, that individuals who are unfortunately born to high ACE parents are at risk for significant adversity themselves, and any intervention that we have needs to take this 2-generation approach to try to mitigate the transmission of future ACEs to offspring. Next slide, please. And this slide just shows you the average ACE score, by age, and what you can see is that even at that early range, so as many of you know, we think about the window when kids are most sensitive to these traumatic experiences as being between the age of 0 and 6, and you're seeing kids starting off early in life with an ACE score of 2.5 on average, which quickly takes off when they get into their early childhood and in early teen years as well. And so thinking about ways to prevent this ACE score from increasing is important, but also minimizing the exposure, particularly early on, of kids when they're most sensitive to these experiences is important as well. Next slide, please. And so then in our additional work is we wanted to actually look at how ACEs are associated with the health and well-being of Crittenton females, and why this was important, because we know that in terms of long-term outcomes, organizations and agencies have metrics that they are focusing on, but we know the steps to achieving those metrics are all about improving the well-being of these individuals. So how well connected do they feel to their peers and adults? What's their coping strategies? What sense of meaning and purpose do they have in their life? And so in our group here at the Children's Hospital of Philadelphia, we have developed a high level of expertise in developing self-reported measures of well-being and health, ranging from things to self-reported sense of meaning and purpose in life, persistence, coping, psychological stress, and sense of connection. And so we offered the agency this opportunity to identify as a test 3 domains that they would like to include as part of this study to look at the association between these measures of well-being and ACE scores. And the way we developed these measures was to actually the same approach that I'm using in developing this youth-informed ACE measure. It's going to young people as the authorities in their life and asking them to give us the definitions and conceptualizing and helping us grasp the terms that they use to describe their own psychological stress and sense of connection. Each one of these measures is on a scale ranging from 0 to 5. I'm going to show you the average score by ACEs, and we'll start off with psychological stress. So these are the young women's own self-reported levels of psychological stress by their ACE score. And so as the numbers increase, that's actually bad. So that means it's higher levels of psychological stress. And what I want you guys to see is that you see that same dose-response relationship. As the ACE scores increase, their average levels of stress or self-reported stress increases as well. Next slide. So this slide shows you the average level of self-reported connection amongst the Crittenton females. Here, once again, this measure is on a 0 to 5 range, but the lower the number, lower the score, the worse off, the lower level of connection that these women are endorsing. Why is this important? Because when I give talks around the country and talk with people about what we do about ACEs, the research that we know works. What works to mitigate these experiences is having a secure and consistent connection with a consistent and loving adult. And what I'm showing you here is that same dose-response relationship. As an individual's ACE score increases, their own level of connection decreases. Why is that important? Is because the intervention we know that works to mitigate the impact of ACEs on outcomes, the most traumatized and vulnerable young women are endorsing the lowest levels of this intervention, the lowest sense of connection with their peers and adults. Next slide. And then thinking about positive coping skills. So, one of our strategies is how can we get these young men and women who have been traumatized to adopt healthy ways to manage their stress and deal with their challenges. So talking to other friends, talking to adults in their life, exercising, and things like that. And so this shows the young women's self-reported level of self-reported coping skills. And once again, on that 5-point scale, the lower the number, the worse off. And you see, once again, a dose-response relationship. The higher your ACE score, the lower your self-reported coping skills are. Next slide. So I think I hand it over back to Jeanette at this point. Is that correct?
Okay, so Jeanette is now going to be talking about the policy and practice implications. First of all, thank you very much, Dr. Wade, for that very rich overview of the findings. And Crittenton has been busy analyzing those findings in partnership with Dr. Wade to really understand what are the implications for broader policy considerations, as well as practice implications for Crittenton agencies and other providers that serve girls and young women. So, Jeanette?
Great, thank you. So next slide, please. So as that last slide indicated, this is really a pretty high-level analysis of what the kind of first cut of implications are, and we're going to continue to call through the data and do more research and have more conversations before we come up with sort of more specific points of how this should impact policy and practice. So just a couple key findings. One, as Dr. Wade said, it was a surprise to us too that we needed to, as Dr. Wade described, really look at girls with scores of 4 to 7 and 8, 9, and 10. The last time we did the ACE, we really just took more of the traditional, girls who had scores of 4 or higher. And I think what this really showed us, particularly as you look at the outcomes in terms of trafficking and out-of-home placement, that we really have to focus on overall exposure to ACEs and other forms of adversity, but be mindful that even within this group of really marginalized girls, that there are differences based on their exposure and their childhood adversity. And so we'll work more with our agencies to really analyze that and talk more about what that means in the future. I don't think it's a surprise, just as in the Kaiser study, women tended to have higher scores than men. Similarly, girls' ACE scores are higher than boys. And importantly, there are differences in prevalence of individual ACEs. Sexual abuse comes to mind initially because the prevalence between boys and girls are very much different. And I think what that tells us is that we really have to use a gender lens. So juvenile, as an example, the juvenile justice system has acknowledged and really working with, both in terms of practice and reform, looking at what drives girls in the juvenile justice system that is different from boys, and what does that mean in terms of how do we appropriately support the girls and their families. But we're not doing that in child welfare. So as we look across sort of the systems that are meant to support and help individuals and families, we really do need to use a gender lens. That is neither better or worse, simply different. Next slide. So as I said, here we're looking at the number of females in our study that had a high number of placements and have been trafficked for sex. Again, is the importance of really looking at individuals where they are and take a broader brush stroke approach and look at just 4 or more really misses the needs, the unique needs of girls who are perhaps the most vulnerable and at risk of entering the systems, but even become more vulnerable once they enter sort of the systems of care, as we call them. And again, the next finding is we look at the ACEs. They're prevalent for girls across all racial and ethnic groups. And you can look at the scores of white girls and girls of color, but that's very simplistic. So as we move forward, we really want to look at the data through an intersectional lens and look at how race, gender, ethnicity, and class, and perhaps rural, urban differences, how do they impact the lives of girls and their families, and really use that as the kind of bedrock foundation for identifying and eradicating the negative impact of high ACE scores on very specific groups of girls in this larger population of marginalized girls. Next slide, please. I think the children of parents with high ACE scores is, I don't think there's really much we need to say about that. I mean, there is no doubt that a 2 or multi-generational approach offers the best opportunity for parents, to stop that cycle. And when you have the opportunity, as I do, to talk with lots of women who are young moms or who were young moms with children, and they learn about ACE, the first thing they say is, why didn't anybody tell me about this? Change the context for them, the decisions they make. And I think it really, rather than demonize young moms because of what we see in this data, we really need to provide them opportunities to be self-empowered through the knowledge and support we can provide, so they can break these cycles in one generation, because they can be broken in one generation, but not without support. And then again, I think this is the last one, the initial results. I think Crittenton agencies have always identified that a key factor is relationships, and all the data says that caring adult. But I think we need to think about new and different ways to create connections for young people. We're very much focused on family, and that's very important, and that's essential, and family first and all that. But there are other ways to do that, I think, and we need to begin to look at that, because those lack of connections have such a tremendous impact on an individual's ability to cope, to manage stress, and to thrive. Next slide, please. So the next step for us as a family of agencies to do further analysis of the data. We will be releasing a policy brief in the coming month or 6 weeks that will delve a little bit deeper, and then we plan in sort of over the next 6 months really to look at generating some population specification briefs. Next slide. So from a bigger picture, where we're going to go with sort of our building evidence process, which is what the family of agencies and Catalyst calls it, really is our intent is to develop and administer a girl or youth-informed survey based on the ACE. While Crittenton agencies ally with each other through this historic commitment to supporting the needs of girls, virtually all of our agencies serve boys too, so our intent is to do most likely a girl, youth-informed tool for girls and boys that will look at a range of different factors that we're still really only at the beginning of the process of defining, but really something, as Dr. Wade talked about, he did in Philadelphia, what really reflects the reality and the context of the lives of young people today. We're going to move forward and develop a central database for what we're collecting. It was really great for us to be able to work with CHOP and use their REDCap system, but we really, over the long term, want to use this on an ongoing basis, so we're tracking outcomes, and so we feel like we need to develop our own. And then just continue to administer well-being questions that address not just connection, stress, and coping, but other well-being domains, so we can really look at and analyze it. It's sort of the secret sauce, connection, stress, and coping, or are there some other, what are the other mitigating factors, or what domains, if we have to make choices, should we be prioritizing? So that's sort of our next step on a broader scale, and we hope pending the receipt of funding, we hope to, have that youth-informed version ready, and hopefully even try to pilot it later on this year. And I think I'm now turning it back over to Jennifer, if I'm correct. There you go.
That's right. Well, thank you, Dr. Wade. Thank you, Jeanette. It's been a very rich discussion. I just want to check in with Sarah to see if any questions have come in through the chat line.
Hi, Jennifer. Yes, we do have a few questions. Roy, are you still with us?
I am. Sorry, I was just on mute.
Oh, great. So Roy has to jump off the webinar a little bit early.
I can stay on. I can stay on. I'm sorry.
Okay.
Yeah, I'm sorry. I changed the schedule.
Great. So Jennifer, do you want to talk about the toolkit and then we can go to the questions?
Great. Yes. If you can stay on, Dr. Wade, that's terrific. So I'm just going to spend a couple of minutes talking about the ACE Toolkit providers. As I mentioned earlier, it was developed with funding from Ascend, and we're deeply appreciative of that. We're often asked, and the agencies are often asked in their own communities, how did you do this? Why did you do it? What did it take? How has the experience been for your staff? How has the experience been for the young people who took the surveys? So we really wanted to be able to put something together that would give very practical advice and very practical kind of tips for how to do something of this nature and how it can be adapted to use in your own agency. So for those providers who are on the phone, this we hope will be a resource that you can use. That there are contact information in there so that if you have questions for Crittenton, you can just email them. And ask, even if you're thinking about doing it one way and it's different from the way Crittenton did it, you can ask, what do you think of this? Do you think it's advisable? Did you try this, etc. And the agencies are also very open to being contacted to find out what their experience was. So the first thing, in terms of the contents of the toolkit, the first thing that the toolkit does is it talks about, the purpose and the goals for administering the ACE. And in talking to the agencies, we really see sort of four central purposes. And the first is really at the individual level for the individuals with whom you're working to support screening, assessment, treatment, and self-empowerment. So that's really about promoting healing for individuals who are impacted by childhood trauma. So the ACEs really provides a snapshot of the childhood adversity that somebody has experienced, and then can be kind of a door opener or a starting point to talk to individuals about their trauma history. So we're really clear throughout the toolkit that this is not an assessment. I think it's one of the things the agencies really wanted to make sure that people were not talking about it as an assessment, because they have many, many assessment tools that they deliver, that they conduct, and this isn't something where you would do an assessment and then expect that your treatment interventions are going to cause that assessment to change over time. It really is just a guideline and used by the agencies as a screening tool that informs the start of treatment planning. So that distinction is really important. The second goal really is to be able to refine treatment interventions at the agency level. So to use the information to be able to customize service interventions and to use the ACE findings to be a complement to other tools that are already being used to understand what's working with different populations. The third purpose is really to educate the broader community, so working with other service providers, other stakeholders, to educate them about ACEs, to educate them about trauma, about what it means to be trauma-informed, about the importance of responding to trauma in a compassionate way, and really opening people's eyes to how their behavior can either promote healing and resilience or further exacerbate trauma. And then the fourth goal is really to inform public policy. So, from the perspective, they wanted to be able to take the findings from the Crittenton agencies and across the Crittenton agencies and be able to effectively advocate for additional resources, both public and private, to be able to to be able to promote trauma-informed systems and trauma-informed public policies. So those are kind of the different levels at which we're hoping that the ACEs work will be able to influence, and certainly the way that Crittenton agencies are using ACEs findings. The second thing that the protocol does is it provides practical tips for providers. So we started off thinking we'd have the top 10 tips for providers, and we ended up with 20 tips. So I won't go over each one of them. You can see them in the toolkit itself. But they're things like what I mentioned before, reinforcing that it's a snapshot of childhood adversity and exposure to childhood trauma, but not an assessment. The importance of using a protocol to make sure that you're having a consistent way of administering the survey, doing some training with your staff so that everybody understands the reason why you're doing it, how to talk to respondents about the purpose of the survey, et cetera, to make sure that you're really addressing how you'll store the information and the results of the survey, and to ensure confidentiality for the individuals you serve. And then how you can use, another tip is how you can use the data and analyze the data for funding proposals, for advocacy influence, et cetera. So those tips are really, again, practical, and they're meant to take what we learned and share it with the rest of the field. The third thing that the toolkit does is it shares the protocol that Crittenton agencies used, and the Crittenton agencies felt really strongly, and as Jeanette mentioned, we developed both the protocol as well as the survey itself with the agencies. They all had a hand in being able to develop the survey as well as the protocol, and the reason they felt very strongly that there be a protocol is to be sure that there were consistent standards for administration. They really wanted to address concerns about the possibility that this could be administered by the wrong person, could be administered by somebody who didn't have a firm sort of foundation for what trauma is and how it impacts individuals, and some kind of background or at least understanding of what the original ACE study found and the reasons why the agency is administering this. So the protocol addresses a number of factors, like the purpose for administering the survey, the target population, the need to define the target populations, the qualifications of the people who should be administering, where physically you should administer the survey, when you should administer the survey, and several steps for actually how to administer the survey and to talk to respondents about it, and then guidance for how to complete the survey in whatever database you happen to be using, which in our case was REDCap. So the sample protocol is in the toolkit. We also have agency case studies. There's a case study from Topeka, Kansas, from Wheeling, West Virginia, and from Southern California. All of these agencies were administering it with a slightly different population, with a slightly different, in a slightly different service setting, and so it shares not only how they administered the survey, but how they're using the results now, which is a combination of really policy impact, funding, to be able to access additional funding for the populations that they're serving, and community education. We also have testimonials from young women who took the survey. I think one of the things we hear quite often is the concern, and we hear this from a lot of different corners, the concern that actually taking the survey can be further traumatizing for individuals, and I think the agencies as well as the young women who have taken the survey with Crittenton agencies have found that that is not the case, and that in fact it is incredibly empowering to understand that not only are you not alone and that there are other people who have experienced this childhood adversity, but it is able to help them put into context some of the impact of that childhood adversity in their adult lives, as well as to be kind of a further motivator for trying to reduce the impact of ACEs for their children. So those are very powerful testimonials, some very powerful quotes for the young woman that you can read in the toolkit. And finally, we have a 1 or 2 pager on resources on ACEs for those who are interested in doing some more exploration into what ACEs is, what ACEs means, and a combination of websites, publications, etc., that are available on the web. So that's it for what's in the toolkit. And if we can go to the next slide. That is the URL for the toolkit itself, which you can find on the National Crittenton website. So we are now going to go into the Q&A section, and I understand some questions have been posed on the chat room. So I'm going to turn it over to Sarah to ask those questions.
Great. Thank you, Jennifer. So we have lots of questions that have come in. We have about 14 minutes left in the webinar, and I just wanted to share a couple notes to begin with. One, if you have your hand raised for a question, please make sure that you've put your audio pin in so that when I call on you, you're audible. If you can't figure out how to do that, you can feel free to type in your question. I'm going to start with the typed in questions. The first one is about the slide availability. We will be posting the slides on the Ascend website, as well as National Crittenton Foundation may be able to post them on their website. We will also be posting the recording of the webinar, so you will have both those items on the website. So I'm going to just kick off with questions that are directed to Dr. Wade first, and we'll go from there. If we don't get to your question, please feel free to send it to Jessie, whose email will be on the last slide, or you can type it in and we will share the question with the speakers and post answers to our website. So kicking off, the first question is from Lindsay Rosenthal, and she asks, how did you screen for sexual abuse given the notorious underreporting? So given that sexual violence was the one exception to the dose response, it has unique and specific significance for long-term outcomes in the original ACE study. Did you see any unique patterns here? And that's for Dr. Wade.
So I think we certainly saw a higher prevalence of sexual abuse amongst the population. I mean, we should note that we purposely targeted women as part of our assessment, and so there may have been a higher prevalence because of that. I've also done some work to suggest that the prevalence for men is actually underreported, and so I think we also need to take our data in with that perspective as well. But I think the major point that we wanted to highlight, and that I hope I conveyed, was that there's this idea that there's this general idea that it's all about sexual abuse for traumatized women. And I think that for the respondents that we had as part of our assessment, there really was just an array of different traumas, even for the individuals who were in the 4 to 7 range. And while sexual abuse was a common experience to which they endorsed an array of different traumatic experiences. And so trying to think about targeting a decrease in sexual victimization amongst women is important, but also thinking about all of these traumatic experiences and what are we doing broadly to try to decrease exposure to these caustic life experiences is key as well. I hope I answered.
And I think that, if I could add something really quickly, this is Jeanette. I think that the agencies, both in the first administration and second administration of the ACE, were very clear with us that they also, just as Dr. Wade said, they said there's significant underreporting too. So it's self-disclosure, and they know that certain young women have experienced certain things, and yet they may not have disclosed it. They may not have answered the question accurately. So I think there's underreporting. This reflects underreporting for girls and boys.
Right, makes sense. So going to the next question for Dr. Wade, this is from Erica Mikowski, and this is regarding the development of an assessment tool for pediatricians. As pediatricians start to utilize an assessment tool to identify childhood trauma, has there been a discussion on what type of follow-up referral or support, such as case management, would be needed for families?
So I think that's a great insight and a big issue. And that's some of the work that we're trying to do, particularly here in Philadelphia, but also across the nation. As you identify individuals and families who have been highly traumatized, what sort of services are you going to provide, and what sort of support do you need? afterwards? And I think we don't know the answer to that question. I think that's part of what we're trying to figure out. And I think that's largely, to a large degree, going to come from families. What are some of the services and what are some of the supports that they need moving forward? So I think that a large focus around ACEs is around behavioral health, and let's identify individuals who are highly traumatized, but because they may be in need of services for PTSD or anxiety, and I think that's important, but not every individual who has experienced trauma is going to necessarily endorse behavioral health problems, and there may be other issues that we need to identify and provide services around. So I think that that's something that we're really trying to figure out. We're really trying to understand. As part of my work here in Philadelphia, I'm partnering with organizations here in the city, and we're trying to answer that question. What's the services that we need to provide to these highly traumatized families?
Thank you. Next question is there any consideration to looking at ACE scores for folks whose gender identity is different from the sex assigned to them at birth, or individuals whose appearance is not necessarily gender conforming? And this is for Jeanette and Dr. Wade. Your thoughts on that?
I think very much we intend to do that. We did have, I'm not looking at the full survey, so I can't remember how it was actually phrased, but that is something that we had extensive discussions with the agencies about, and I am sure that when we do the youth-informed version, that will be included.
Just to back up what Jeanette said, I think that's another area of research that needs to be done. I think that with some of my initial qualitative work, what I was interested in is that we really haven't taken the perspective of groups of individuals who have been traditionally marginalized in terms of what questions we ask, the way we ask those questions, and also what services we provide. And so I think that's an additional area that needs to be investigated and understood.
Great, thank you. This next question is also for Dr. Wade, and it's about the data. Could you explain to the audience once more how there was an inclusion of more girls in the study versus boys? I think she's referring to the children, but just explain the gender differentiation in the study.
Well, I think we wanted to, purposely, we wanted to look more at the experience of adversity amongst Crittenton girls, but we also included boys in the assessment as well. For the child assessment, we offered every individual, including men, even though that data that I showed you was focused on women, the opportunity to provide an ACE score for any of their children as well as part of the assessment. So it was a totally optional portion of our assessment, and I know that there are limitations with that, but what we wanted to start to do was to begin to understand what is the connection between the adversity that parents are experiencing and their children are experiencing. So just to summarize, we targeted girls for the survey, but we also included boys, and the child assessment was optional.
Got it, thank you. Next question is for Jeanette. Jeanette, can you talk a little bit more about how the second administration of the ACE study and the subsequent toolkit that you've developed has first impacted how your affiliate sites approach treatment and service, and then also how you're looking to influence other organizations?
I think the way in which the use of the data is very much customized by each individual agency. So for some agencies who do not have as deep a therapeutic focus, it may be kind of a first step into expanding their continuum to have the inclusion of more therapeutic services. I think in agencies that we have some that are secure psychiatric residential treatment centers, it was a way to, as Jen said earlier, to create a snapshot that could help to define, in other than very clinical terms, what the population looks like and what are the barriers that they're facing. So I think it really is pretty individual, and I would say to whoever asked the question, if you represent a specific kind of organization and you would like an answer from a very similar organization, you can certainly submit that question in writing, and we'll connect you with the agency that sort of most closely matches your population. And Sarah, can you remind me of the second part of the question?
The second part of the question is how would you like, or how do you see the lessons from this particular administration of the survey influencing other organizations?
Well, I think, well, in organizations that are currently sort of have a focus on girls, I think this was a wake-up call for us, too, that even we need to be more specific and more, need to dig deeper in how we look at the data and how we experience and support girls who we call marginalized, whatever the term, you know, who have faced a lot of childhood adversity, because I would not have expected the kind of significant difference between a 7 and an 8 score that we saw in the data. So for us, that is something that we're going to think about and figure out what does that mean, both in to our direct service provider, to the family of agencies, but also to you know, from a national perspective, what does that mean in terms of policy? For example, if you look at girls with scores of 8, 9s, and 10s, are these the young women who end up involved in multiple systems? You know, so what does that really mean? And we still have a way to go in determining that. For organizations that right now have a focus primarily on boys, or who frankly don't distinguish different sort of contexts for their lives between boys and girls, and don't reflect kind of different service options or services based on the experience of girls and boys, I think it should be a wake-up call. The gender does matter, and that doesn't make one better or worse than the other, but if our goal is to effectively provide supports and opportunities that lift young people and their families up, we have to use a gender. We actually have to use an intersectional lens that looks at race, gender, class, sexual orientation, gender identity, disability. We have to be much more specific, because the context of the lives generationally for people in different communities is very different, and we can't support them effectively if we don't acknowledge that and understand what that means to us as service providers and advocates.
Jenna, can I follow up that as well? Can I follow up that as well?
Sure. Please.
I was recently approached by an organization here in Philadelphia that serves a highly traumatized population, and one of their pushbacks for, you know, they understand and they're steeped in the ACEs literature, and they understand its impact on health, and one of their concerns was, well, why bother to do an assessment, because we know that our individuals are highly traumatized, and we know that their ACE scores are going to be, you know, huge. And so how does that really inform what we do? And I think, you know, I pointed them to what we had done here with the Crittenton study, and how we showed that even though our girls and boys had high ACE scores, there was still a gradient effect, and we could see certain subpopulations who were more at risk for poorer outcomes because of their traumatic experiences. It was just a matter of constructing and modeling the variables correctly so that we could actually see that signal. And so I think that even amongst highly traumatized populations, it is a marker of increased risk, and it can help you to identify populations who are going to be in particular need of certain services and who are particularly at risk for poorer outcomes.
Right. And one more comment. I would say that let's look at it from the perspective of, you know, young women and women, given Crittenton's work, who are 8s, 9s, and 10s, who have broken these generational cycles, who have been very effective and very successful and are thriving and are giving back. So it's also a call for us to work with them as partners and leaders to figure out, you know, so what worked for them? Why were they able to do that, given all the odds and all that we know about ACE and brain development and toxic stress and complex trauma? They made it. They're making it. We need to know why and what that means.
Right. Well, we've got about a minute left, so we've run out of time for questions. We've had a number of questions come in that we did not get to, including some for Ascend around 2Gen, but we wanted to make sure the audience heard from Dr. Wade and Jeanette. So we will be organizing these questions, sharing them with the speakers, and organizing responses to questions. If you have your hand raised and didn't get a chance to ask your question, please type it in and we'll capture that. And I will turn it over now to Jennifer and Jeanette. Thank you all for joining us. And again, Ascend is just really privileged to be working with the National Crittenton Foundation on this project.
Thank you, Sarah.
Thank you, Sarah. We're really heartened by the response to this webinar. We're really heartened by the dialogue that's opened up as a result of ACE work, ACE survey results, and the use of the ACE survey. We appreciate all the time that you've taken to listen to this presentation. And again, Jesse's email is still up on the screen, so write it down now. And any questions that come up after the webinar that you didn't get a chance to put into the chat box, please direct them toward her, and she'll make sure they get to the right person. And I hope you all have a great rest of the week.
Great, thanks. Bye-bye.